have the opportunity also to introduce our first speaker, Katherine Puddifoot. Kathy and I were once colleagues at the University of Bristol a number of years ago, and then after that she went on to a postdoc on the European Research Council funded project, Project Perfect at the University of Birmingham, and she is now at Durham University. Kathy has done a lot of exciting work, in particular on issues of bias, and it relates to ethnicity and race, and also to gender, issues of epistemic justice, and in particular on how these relate to medicine. So she is the perfect person really to kick off this this workshop, and yeah, and it's a particular pleasure for me as an ex-colleague of Kathy's to have the chance to introduce her and her paper. So right, yes, timing perfect. Okay, Kathy, over to you. But before you start, can I just remind everybody to mute your microphones? You keep your videos on if you like. So it's nice to have faces to see, but please turn off your microphone so you don't accidentally sort of let your dogs or sort of participate in the event unintentionally. Great, Kathy, over to you.
Okay. Okay, thanks very much to Alexander for that introduction, and of course to the organisers, and for all of you for coming along to listen to me. So today I'm going to talk to you about what I'm calling in this talk social generalisations. In other words, I've just called them stereotypes, but I want to remain neutral about whether we're defining these things as stereotypes or not for at least the beginning of this talk. So the question I'm going to ask you is, ask you to consider here is, how can medical educators ensure that their students use social generalisations appropriately? Okay, so what am I talking about when I talk about social generalisations? I'm talking about generalisations about social groups, and more specifically, generalisations like group A are, or more likely than another group, to X, Y, or Z, where this will usually involve having certain characteristics. As I just mentioned, in some work I just call these social stereotypes, but I'm going to not use that terminology, at least for the beginning of this talk. Okay, so my strategy is going to be to first of all consider some ways to conceptualize social generalizations, in particular by forming generalizations about social generalizations. I'm going to then argue that none of these generalizations about social generalizations work, before attempting to diagnose why these generalizations don't work, and then showing how medical educators should respond to the failure of these generalizations about social generalizations. Okay, so I'm going to start then by going through 3 different types of generalizations that you might think is appropriate to make about these generalizations about social groups, showing that none of them really work. Now, I think you just have to bear with me a bit here, because the generalizations get less naive as we go on. So you might think, oh, what she's talking about is wholly implausible, but hopefully by the end you'll not think that. Okay, so the first type of generalization that you might find people making is that all generalizations about social groups in medicine are harmful, or all generalizations about social groups are beneficial. Again, as I state, these might seem a bit naive. But I think that at least the first of these generalizations might have some appeal to some people. So some people might think that if you're in particular in a clinical interaction, so you're a healthcare professional interacting with a particular patient, then your focus of attention should be on that individual, their symptoms, their medical history, their personal history, information about them. And it might seem as if it's just going to be most profitable to focus in that way on the individual. And it might seem as if you're focusing on their social group membership, what you're really doing is focusing on facts about other individuals who are part of their group. And this sort of idea might really appeal to you if you're influenced by work on other stereotypes. For example, when Jennifer Saul talks about stereotyping in philosophy, she argues that when you're evaluating an individual and their capacity to do good philosophical work, their gender or their race or their other aspects of their social identity are irrelevant. And if you're focusing on those pieces of information, you're just focusing on irrelevant details. So if you buy that argument in that domain, you might think it also applies in the medical case. But there seems to be a sort of obvious response to this sort of worry, which is that social generalizations in medicine can track genuine correlations. As already been mentioned, some conditions are more prevalent amongst some social groups than others. This is like the basic idea underlying there being health disparities, right? There are disparities, there are differences in the prevalence of conditions across different social groups. And on top of this, you have a situation where in many cases, the symptoms that are presented by a patient, their personal history and their medical history could be explained by many different conditions. So if you think that, if you think about the task that needs to be completed by the person engaging in diagnosis, it can seem to be an intractable problem to simplify the task from there being numerous different diagnostic possibilities to there being only one correct diagnosis. So the use of these social generalizations can simplify the task by allowing the healthcare professional to focus on those clinical possibilities that are more likely. So, you know, I think this generalization that all generalizations about social groups in medicine can be harmful has some appeal, but can be dismissed. Okay, so what of the other generalizations, sort of the other side, the flip side of that, which all generalizations about social groups in medicine are beneficial? Again, I think this seems clearly wrong, but it's interesting to consider why, because I think if you consider why it seems so obviously wrong to make this generalization, you find a route to other generalizations that will seem more plausible, but which I also want to reject. Okay, so I think the two main reasons why people would reject the idea that all generalizations about social groups in medicine are beneficial is that some generalizations are social stereotypes about character traits. So if you're going to allow in all social generalizations into medicine, say they're all beneficial, what you're doing there is implying that when social groups are stereotyped as lazy or uncooperative or lacking personal responsibility, that these stereotypes are going to be useful because they're part of this general group of social generalizations, which on this generalization we're considering is going to be beneficial. So that's one reason I think why it seems just completely wrong that all generalizations about social groups in medicine are beneficial. The second reason is that some generalizations are false. Okay, so clearly, you know, if you're allowing in all social generalizations, you're allowing the true and the false ones in, and this is intuitively really problematic. Okay, so these are two reasons I think that you might reject this generalization. I think they're good reasons to reject the generalization. Social stereotypes associating groups with characteristics, character traits can be harmful to clinical judgment and decision making. It might seem obvious, but here it's just an example of a few ways that it can be. So if members of a certain social group are associated with certain characteristics, this can lead to false assumptions about their condition. So say you have a person who presents as living in poverty. You might associate those people who live in poverty with being lazy. So this would be a stereotype, a social generalization associating the individual with a character trait. If you make this association, this could lead you to assume that the patient who is presented in front of you is inactive, and lead you to think it's likely that they have conditions that are associated with inactivity. If the stereotype is wrong and you falsely associate this individual with this character trait, and you could easily end up falsely ascribing them with a condition that they don't have, which is associated with inactivity. On top of this, you have this problem of testimonial injustice, this version of epistemic injustice, where if you associate individuals with particular negative character traits, like insincerity or unreliability, then you could fail to give their testimony credibility when it should be given credibility. And in a clinical setting, this could mean that you don't listen to them when they explain their symptoms or their worries or facts about their medical history and their personal history. On top of this, these problematic stereotypes relating individuals to character traits can lead to a breakdown in trust if a healthcare professional indicates in their behaviour in any way to a patient that they think that they are lazy or uncooperative or any of these things, which then, you know, these stereotypes do manifest in behaviour, at least sometimes. Perhaps you might say not always, but they can do. If the patient picks up on these manifestations in behaviour of these negative stereotypes, it can lead to a breakdown in trust between the patient and the healthcare professional. And this can lead to long-term harms to the patient if, in response to being stereotyped, they then choose not to in the future engage in help-seeking behaviour. But don't expect that this is a full and complete list. It's just a list of some of the various ways that it seems right that if you stereotype an individual due to social group membership as having certain character traits, this can be problematic in a clinical setting. And then one reason to reject the general idea that all social generalizations in medicine are beneficial, because some of them will include these and these are bad. I think there's also good reason to reject the generalization that all social generalizations are good on the basis that some generalizations are false. So if you make a false association between a social group and a certain characteristic, that's unlikely to lead to a correct judgment about that individual who you apply the association to. I have argued in other work that actually there can be some rare cases where making false, inaccurate associations can be beneficial, but in most cases it's not going to be the case. Say, for example, if you associate members of a certain group with a condition more strongly than others, but the condition isn't more prevalent in their group than others, then making that association and applying it to an individual is unlikely to benefit you. It's unlikely to lead to a correct judgment about which condition is present. So then, I think there are good reasons to reject the generalization that all social generalizations in medicine are beneficial, and the good reasons are the ones I've just described. But the problem with these claims that these are the reasons to reject the generalization is that they can lead to people to make two further types of generalization, I think. So once you reject the idea that all generalizations in medicine or social generalizations are useful on the basis of these two reasons, you might think that two further generalizations are correct, which I want to reject. So the first type of generalization that might be tempting is that all medical stereotypes are beneficial, but all stereotypes about character traits are damaging. Okay, so medical stereotypes are here being defined as generalizations that associate members of some social groups more strongly than others with particular medical conditions. So given that I've just explained various ways that associating individuals with character traits can be problematic, you might think, well, yeah, that's where we locate the problem, that these social generalizations can associate people with problematic character traits. But if you focus on those associations that are tracking reality in some way, tracking the prevalence of medical conditions across different groups, these medical stereotypes, then these aren't problematic. These are always going to be beneficial. A second type of generalization you might be tempted by is that accurate medical stereotypes are beneficial, but inaccurate ones aren't. Okay, so one reason for rejecting the idea that all social generalizations are beneficial is that some are false. So what if we just focus on those that aren't false, those that are accurate? Maybe we can say of those at least that they're always beneficial and never harmful. Well, as I said, I want to reject both of these generalizations. So why reject the first idea? The first idea that if you focus on medical stereotypes, these associations between social groups and medical conditions, that these are okay, that you can generalize of these, that they are all beneficial within a healthcare context. Well, we can't say this because, first of all, it's not really possible to separate out the medical stereotypes from others, so stereotypes about character traits. if you look at the psychology of stereotyping, so how we tend to engage in social categorization, what appears, at least on most accounts of how we do this, is that we don't make single associations. We don't make separate associations with the social group. So we don't, for example, associate South Asian patients with type 2 diabetes on the one hand, and then separately associate South Asian people with certain characteristics. Instead, what we do is we tend to have a cluster of associations that we make with a social group, such as South Asians, and that cluster will include those associations we make that relate to medical conditions, but also those that relate to personality traits and characteristics, which means that if we apply a medical stereotype to an individual, then we're likely to also have triggered in our mind other associations that we are disposed to make with their social group. So if this is right, then we just can't say that medical stereotypes are okay, because when we apply the medical stereotypes, we're susceptible to engaging in the other sorts of stereotyping as a result. But say that that wasn't true, and you could just apply medical stereotypes. And in doing so, you were just shielded from making any associations with individuals and character traits. Would this be acceptable? Well, no. I want to argue that even medical stereotypes can lead to diagnostic errors and poor treatment decisions. Okay, how can they do this? Well, here I'm drawing from the psychological literature on stereotyping. And in this literature, they identify various ways that when people engage in social categorization, they, as a result of doing so, respond poorly to information about individuals who they stereotype. So I'm going to go through various different biases that people tend to undergo when they engage in social categorization and show how they can occur when medical stereotypes occur. And here I'm going to appeal again to the stereotype associating South Asian people with type 2 diabetes. This is useful, as we'll see in a minute, because actually this is, in the UK, it is the case that South Asians are highly more likely than white Europeans to have type 2 diabetes. They're 50% more likely. So here we have a medical stereotype that's tracking the reality out there, and yet I'm going to argue that it can lead to errors in clinical judgment and decision making, suggesting that medical stereotypes aren't always useful and they can be harmful. So one finding that's been made in the psychological literature is that where people engage in social categorization, they can misinterpret ambiguous behaviors. So studies have shown, for example, that if you are told the race of an individual and you see them or you hear that they've been engaged in certain behaviors, or you engage, so you say you read a description of them engaging in certain behaviors, you're more likely to interpret the behavior as aggressive if they're black than if they're white. And this suggests that where you have ambiguous behaviors, so behaviors that could be interpreted as, for example, just like playful shoving, or could be interpreted as aggression, the behaviors are interpreted as more aggressive in the way that's fitting with the stereotype of black people as aggressive when a stereotype is activated. So that's a general effect. This effect could occur in the medical context, given that people engaging in clinical judgment and decision making are human beings and prone to the sorts of biases that we're all prone to. They could, as a result of making an association between individual social groups and medical conditions, misinterpret ambiguous symptoms in a way that's consistent with them having stereotypical conditions. So a South Asian might be presenting in a way that they have symptoms that could be interpreted as consistent with various different conditions, but the focus of attention might be on a stereotypical condition, this type 2 diabetes, and symptoms might be read in a way, interpreted in a way that's consistent with them having type 2 diabetes, even if they could indicate the presence of other conditions. On top of this, you could have a case where, perhaps because of this or because of other phenomena, healthcare professionals could fail to consider non-stereotypical conditions. So it might be the case that South Asians are more likely than the general population in the UK to have type 2 diabetes, but that doesn't mean that it can't be more likely in a specific case for an individual to have a different condition, which is actually, that's prevalent amongst the wider population as much as amongst the South Asian population. So here, if a healthcare professional focuses on a stereotypical condition, they could miss out on considering the correct condition on the basis of focusing on the less likely condition, but the one that's associated with the patient in front of them. Another effect that's been found in the psychological literature on social generalizations is that when people engage in stereotyping, they often falsely assume that there's similarity between members of an individual social group that aren't there. So one finding that's particularly striking is that Black women are often viewed as interchangeable. So when asked to identify whether they previously encountered a certain Black woman, people are very prone to error because they are poor at recognising the differences between those people who belong in this category and are viewed as Black women. So in the medical context, what could happen is that if you, for example, encounter a individual Black female patient, you might have activated in your mind the stereotypes of Black women, and as a result of this, assume that the individual in front of you has certain conditions that previous Black women you've encountered have, and falsely assume this, and therefore shift up your list of possible clinical hypotheses, those conditions that you've encountered in Black women in the past when you shouldn't do so. On top of this, when people engage in social categorization and engage in this sort of generalization, they often fail to notice similarities between individuals who are members of different social groups, which in the medical context could come out as a failure to recognize the similarity between patients who are members of different social groups. So two people from different racial groups might present with similar symptoms and medical history and personal history, but as a healthcare professional, there might be a failure to recognise that they both have the same condition. So say one's already been successfully diagnosed as having a condition, and you know the healthcare professional has a potential to learn from this experience and learn that the signs that indicate the presence of this condition, they might nonetheless fail to do so and fail to recognise in the other individual that they have the condition, because of this tendency that people have when they engage in social generalisation to fail to recognise the similarity between individuals who are members of different groups. And a final effect, actually there are more, but I think this is a long enough list for the moment, but a final effect that can occur as a result of this sort of social categorization that I want to mention is that when people are viewed through one aspect of their social identity, they can often have other aspects of their social identity that are relevant not noticed. So let's return to the South Asian patient again. So say that a healthcare professional is focusing on the fact that a patient is South Asian in the UK, and as a result of this, they're seeing this individual through the lens of their medical stereotype of South Asians. One result that could occur as a result of this, that seems to be fairly common based on psychological literature, is that the healthcare professional will fail to notice other aspects of that patient's social identity. So say that the healthcare professional is working in East London. In East London, a large amount of the South Asian population are Bangladeshi, and Bangladeshi people are more likely, they have very high levels of deprivation. So it could be that the healthcare professional associates South Asians with poverty, and a result of viewing this individual patient through the lens of being South Asian, associates them also with poverty. As a result of this, they consider as highly likely medical conditions that are associated with poverty, but they don't consider conditions that are associated with more wealth, so being middle class conditions. So this could happen because by focusing on the one aspect of the individual's social identity, they could fail to notice another aspect of their social identity, which is their relative wealth, or indicators of their wealth. Okay, so there are all these problematic effects that can occur as a result of the application of medical stereotypes. This provides good reason to reject the idea that all medical stereotypes are beneficial, and it's only those ones that associate individuals with personality traits or character traits that are problematic. Now, what of this other generalization? So the generalization that it's of course problematic to focus on inaccurate generalizations and to associate social group members with characteristics that aren't more prevalent amongst their group than others. But it's okay to associate social group members with characteristics if those characteristics are more prevalent amongst their social group. Well, I think we've already found reason to reject this in this example of the South Asian patient that I've been considering on and off in the last section of the talk. So here you have a medical stereotype that a person might make. They might strongly associate South Asian patients with having type 2 diabetes, or they might associate South Asian patients with having type 2 diabetes at a higher rate than others. But as a result of the application of this stereotype, as a result of making this association, the healthcare professional could make all sorts of errors like those just described. Okay, so they could misinterpret the symptoms displayed, they could fail to consider probable hypotheses, and so on. Okay then, so where are we? Well, I think there's reason to reject the idea that easy generalizations can be made about the use of social generalizations in medicine. So that's a fairly negative point. So I think it might be really tempting to seek out easy generalizations that can be used to guide medical practice and medical education. But these easy generalizations aren't available. We can't assume any of the following are beneficial or harmful consistently across the board. So social generalizations in general, medical stereotypes, or accurate stereotypes, including accurate medical stereotypes. So why is this though? So I don't want to be wholly negative. I think there's something positive to be said here too. And the positive thing to say is that the reason we can't make these generalizations is because each of these types of generalizations, so social generalizations, medical stereotypes, and accurate medical stereotypes, dispose healthcare professionals to make errors when they're responding to information about individual patients. So it's important then to focus on dispositions and the way people are disposed to respond to evidence about individuals as a result of harbouring stereotypes, medical stereotypes, accurate medical stereotypes. So then, right, up until this point, I'd say this is all me, but I have been working with a couple of other people to try and come up with some sort of practical suggestions that could be taken on board by medical educators for how they could apply this general argument to practice. And here I have been working closely with my sister, in fact, Claire Puddifoot, who works in medical education at the University of Exeter, and Rona Knight, who was a GP for 25 years and then taught consultation skills at the University of Leicester and is currently a PhD student in Durham. So I want to credit them for a lot of at least pointing me in the direction of some of these ideas for the rest of the talk. Okay, so how should medical educators respond to the argument that I've just given? Well, obviously it's important to continue to instill medical stereotypes, and I gather that this is a fairly large part of the job, so providing information about cases and indicating about those cases that individuals of certain social groups, so racial groups or socioeconomic groups are more likely than others to have those conditions. Okay, so it's important to continue to instill these stereotypes because they're useful in the way I've described in terms of reducing this seemingly intractable task of differentiating between different clinical hypotheses and focusing on those that are more likely. But it also seems to be important to teach students about the potential for error even with these accurate stereotypes. Merely saying it doesn't seem to be enough, although I do think it should be said. So we've been considering how you might use existing tools from medical education to try to provide this information in a way that might be more likely to be used within an actual practical setting of medicine. Okay, so one thought that we've had is that there's a potential to use case-based learning to try and portray this information about this argument that I've been presenting earlier. So case-based learning is one of the ways that medical educators teach their students. What happens in case-based learning is that students are presented with cases like the ones on this slide. They engage in small group work. Students are required to prepare information, do preparatory reading before they go into engaging in group work. They're supported by expert facilitators, so you might have a doctor and a social worker engaging in this group work as a facilitator, and the students and the facilitators work together. So the students can ask questions of the facilitators, and the facilitators can bring students back. If they go off on a tangent, they're considering a case and they're thinking that some condition is likely and it isn't, then the facilitator can bring them back from the errors that they might be making. So I think that this sort of method of teaching could be used in various ways. One potential way, and this is all very tentative, right? So we're making empirical claims here we want to explore in future, but we haven't done yet. So this is sort of an indication of the sort of thing we might think might work, but please let us know if you don't think it would work. But one thing that you might do is use this sort of case-based learning to encourage students to remember and then later in their judgment and decision making be influenced by the possibility that they can make errors due to the application of medical stereotypes. So the idea would be that you could design cases to elicit various errors in judgment. So you could have stereotypical and non-stereotypical information presented, specifically selected because it's stereotypical and non-stereotypical. You could have non-stereotypical conditions being the correct answer. There's a correct response to these cases, and it could be that you sort of trap the students. Seems unkind, but still. And another effect I should have actually to make this argument work a bit better, I should have discussed earlier, was that when people engage in stereotyping, it often affects how they remember. So people often are more likely to remember things that are consistent with a stereotype than information that's inconsistent with a stereotype. So they might be more likely to remember symptoms that are consistent with a medical stereotype than information that's not consistent. And you could sort of play on that in designing these cases by attempting to elicit memories of information in the preparatory reading that are consistent with stereotypes but not really relevant. So the idea is that you could engage students in this practice, highlight the types of errors they're likely to make. The facilitators are there to do this, and the facilitators could also give prompts about how you might avoid this sort of problem. Now, this could be useful because what we know about human judgment and decision making, one thing at least, is that people often depend in their judgment and decision making on readily available vivid examples. So if you have an awkward social situation in which you make the sort of error, it might be a vivid example that could then influence your practice, as long as it's a supportive environment where you're not made to do that. So the idea would be that this would be one sort of way that medical educators could use a tool that's already out there being used, and in doing so, they could ensure that students are aware of the fact that they're likely to make errors as a result of applying even medical stereotypes that are accurate. Another possibility we've been considering, again tentatively, is that when medical educators are selecting consultation models to use to teach their students, they could do this by considering how well those consultation models prepare students to cope with the sorts of errors that they're supposed to make due to the application of stereotypes. So here we have an outline of one consultation model. This is a Calgary-Cambridge model. So consultation models are models that describe how to structure patient consultations. So students are taught that they should follow this sort of process of interaction and reasoning when they engage with their patients. They use as teaching aids in the teaching of communication skills to students. So in this work, Rona Knight's been really important because she's been teaching for a long time, got these sorts of consultation models to students in Leicester. But the idea would be that some of these consultation models do better than others with respect to preparing students to be able to control the sorts of errors they're likely to make as a result of stereotyping. So the Calgary-Cambridge model, that was on the previous slide, is a very popular model. And it describes in detail the various stages of the interview process it needs to go through. And one important thing that's emphasised in that model is that the healthcare professional needs to build a rapport with the patient, and building a rapport and focusing on the cues that the patient demonstrates. These sorts of things are likely to be good in combating the negative effects of stereotyping. If you build a rapport, you might be less likely to stereotype. If you're really focused in on the behavioural cues of the patient, you might be less likely to ignore those behavioural cues and not consistent with the stereotype. So I think that that sort of model is good in some respects, but this Leicester assessment package, which is not exactly a consultation guide, but a model that's used for the assessment of medical students, I think, and we think, has the potential to provide some information, some sort of guidance about how you could do a little bit better than than what is found in the Calgary-Cambridge model. So built into the Leicester assessment package is the idea that students need to, in order to succeed in their medical education, but also their practice, do things like generate appropriate working diagnoses, seek relevant and discriminating signs to help confirm or refute working diagnoses, correctly interpret and apply information, be capable of applying knowledge, and capable of recognising the limits of their personal competence and acting accordingly. So if you think of an individual who is trained and has developed the habits of doing these things well, then they're unlikely to be as susceptible to making the errors that follow from stereotyping as others. So if they are in the habit of checking whether they're generating appropriate working diagnoses, then part of this could be checking whether they're just focusing on stereotypical conditions. If they are considering whether they're seeking out relevant information to help confirm or refute their working diagnoses, then they're going to be sensitive, at least if they're doing it well, to whether or not what they're just doing is seeking out information to fit the medical stereotype they start with. If they're correctly interpreting and applying information, then they're not going to be falsely assuming that ambiguous information is actually consistent with a stereotype. And if they're good at applying their basic knowledge to their knowledge of basic sciences in the clinical setting, then they'll be able to take on the knowledge about the prevalence of different conditions across social groups and apply this without being otherwise biased. And if they're able to recognise the limits of their personal competence, then they'll have the humility which is likely to lead them to engage in those sorts of practices that have just been described. So one thing we've been considering then is whether it's possible to develop a consultation model that in some way integrates problem solving of this type into the model, which and to encourage that medical educators to teach students this sort of model, because in doing so it might enable those students to have the skills that they need to be able to combat some of the negative effects of stereotyping, even when medical stereotypes are used. Okay then, so conclusions. Some intuitive generalizations about social generalizations, they don't work. We can't generalize that all social generalizations are harmful, that all medical stereotypes are useful, or that all accurate medical stereotypes are useful. None of these generalizations is correct, because even medical stereotypes that reflect the differing prevalence of conditions across social groups can dispose healthcare professionals to make false, incorrect clinical judgments. What this suggests is that medical educators should attempt to make students aware of how even useful medical stereotypes can lead them to errors, but also there's a potential to use existing and new tools of medical education to attempt to equip students to have the ability to prevent these errors from influencing their judgments. Yes. For a short time now, we've been considering the possibility that case-based learning and the careful selection of consultation guides might provide two routes to achieving this goal. But of course, I'd be interested to hear of other people, other ways that they think that this could be achieved. Thank you.